Hello everyone. Today I'm going to discuss about PESCI, especially about how to handle a PESCI case. In that, I'm going to discuss a specific PESCI case where I will discuss how you handle this case. First thing about PESCI cases are like a structured clinical interviews, and then one case would run for usually about 60 to 90 minutes. That's like 1.5 hours. So you would be expecting to discuss a lot of things, um, or you should be expected to sort of expect a lot of questions from your examiners or the PESCI board. That means you should, when you get ready for a case, when you discuss with your friends, for instance, you will have to address a lot of things around that specific case. With that in mind, we will start a case and then I'll go through step by step um, how to handle this sort of a case. In PESCI or pre-employment structured clinical interviews, there would be ideally there would be two GPs who would be questioning you, and then there would be another general practitioner who will be the uh, president of the PESCI board, or he would be observing what's happening. But there will be two examiners or two other GPs who will be asking all these questions from you. In that, they will be checking your, clinical knowledge, theoretical knowledge, and how do you examine or examination skills, and then your psychosocial aspect, whether you cover the psychosocial aspect about the case, and then holistic approach when you're handling a case, uh, and preventative aspect related to the specific case. So you are expected to address all these things in a given PESCI scenario. So the example case I got from one of the doctors from Sri Lanka. Um, so the case runs like this. Uh, it's a 76 years old Aboriginal patient presented to the doctor or the GP with tremors and recent forgetfulness. And in the history, he didn't have any history of falls. There is no history of fever. And his past medical history, it is mentioned that he's having hypertension, diabetes mellitus, depression, um, hyperlipidemia, and atrial fibrillation. He's on sitagliptin, atorvastatin, insulin, sertraline, amitriptyline, rivaroxaban, Nicardia, and Becosync. So he lives alone in a rural village. So this is the scenario you will be given by the PESCI exam or PESCI interview, and then they would be asking a lot of questions. So the first thing the examiners would be asking you would be how to take the history from this patient. So you given some background history, but you are expected to ask more questions uh, related to the scenario. So given he's a Aboriginal patient, every word in this case would be important when you try to address the scenario. So he's Aboriginal, one thing, and then he presented with tremors and recent forgetfulness, and he hasn't had any falls, and he's not running any temperature. And past history, hypertension, diabetes, depression, hyperlipidemia, and atrial fibrillation. All these are important. So, and even his medication list I gave you before. Uh, all these are important, and then you have to address one by one in your history, examination, investigations, and management. Uh, so, in the history, what you will be asking now, if he's an Aboriginal patient and living alone, and then presented with tremors and recent forgetfulness, first thing you would be asking like about your differential diagnosis. Given this history, you would be thinking about your differentials. what you would be thinking about is, so the forgetfulness, if you take, for example, you will be thinking whether it's dementia or whether it's delirium, whether he's having any infection like UTI, or whether he's on so many medications. So whether he has any reaction or side effects of medication or interactions of medications. And then if you take into account his past medical history, whether there's any complications from this. Okay, for instance, he got diabetes, so he may be having hypoglycemic episode, for instance, because he's on insulin, and or hyperosmolar non-ketotic coma, because he's not taking medication, for instance. So you have to think about all this. And hypertension again, whether it's not under control or is it controlled, or is he having a stroke as a result of hypertension? So you would be thinking about those. And atrial fibrillation again, you will have to ask questions about whether he has seen his cardiologist recently, or when was the last echo, or is it well managed, or how is it managed? All those questions you would be asking in your history. Then about medications, as I said, he's on many medications. He's more than 5 medications. Then if one patient is on more than 5 medications, we would be considering it as polypharmacy. Then you would be checking whether you can reduce some of those medications, or are they really needed, or are you going to add more? And medication history, and then the compliance, whether he's taking them correctly, or is it taking as advised, or is it stored correctly? Those sort of questions. Then in the history, further about history, this is a person who's living alone. So you'll have to, and then his presentation is forgetfulness. So you have to go about the forgetfulness a bit more to see whether it's only recent memory, or is it long-term memory loss, or what is he forgetting? Is there any accidents happening at home, or has he sort of left his heaters on, or has he left his kitchen stove on, or things like that, and what sort of things he's forgetting. Here, it is very important. I know that he's living alone, but at the same time, you have to mention to the examiners that you're checking to see whether he got any other support around. Is the family lives close by, or is there any other neighbors helping him? And then you would be looking for a collateral history, like asking someone else about his forgetfulness and how bad it is. For instance, if he got a son who's living far away, but at the same time, if the son is giving a phone call every 3 days or so, you can ask from the son about his dad's recent memory issues. Then remember, if we go back to the differential diagnosis, has he had any infection recently? It's given that there's no fever, but at the same time, it's very common that at this age, and given his diabetic patient, so he may be having a UTI, for instance. So you would be asking about those symptoms, like in your system review. So you would be asking from top to bottom, from head to toe, different questions about, okay, from central nervous system point of view, cardiovascular system point of view, respiratory, then urogenital, and then abdominal. Likewise, you can ask a lot of questions about the system review. First thing you ask about the presentation, like presenting complaint and related questions, and then you go for the system review. In that system review, you can ask a lot of questions about the presenting complaint, but related questions. For instance, I can give you an example: tremors. maybe due to thyroid issues, then you can ask about whether he has a history of any hot or cold preference, whether he's having tremors, what sort of tremors he's having. Is it when he's at rest or when he's doing something? And then regarding tremors, again, you can ask about whether there's a family history of any tremors, or whether there's a family history of essential tremor, for instance, those things. Then about the past medical history, one by one, again, you'll have to ask about whether he has any complications or whether it's under control, whether he's taking medication. For instance, hypertension, you can ask questions about whether he's taking his medication correctly, and then whether he has any eye issues, for instance. Diabetes, you could ask a lot of questions about it. Again, what were the sugars? Is it under control? Is he taking medication regularly? Are there any complications? Diabetes itself, you can think about a lot of scenarios, whether he got any diabetic eye disease, or whether there's any diabetic like ulcers or foot complications or things like that. Then comes to the depression. Again, depression, and at this age, about 76 years of age, depression can complicate the presentation. It may be forgetfulness may be related to depression, so you have to check how is his depression. Is he really depressed at the moment, or like again, questions regarding those. There's a geriatric depression scale. You have to sort of check that with the patient or with the family. And atrial fibrillation, again, any complications. Medication history, again, I think I mentioned before, but still you can go again to see whether his compliance, how it is, and then what are the indications. So you can think about different indications. Amitriptyline here, for instance, you're not sure why he's on amitriptyline, you have to inquire. And amitriptyline itself at this age can cause some complications. So therefore, this would be a one medication you're thinking, what is the necessity of amitriptyline, whether you're going to stop, depending on why he's on that medication. Then, so we did cover history now. And then in the history, there's so many other things you have to ask, because he's living alone, and now he's forgetful, and he got tremors as well. Sorry, I forgot something about tremors. You have to think about differential diagnosis for tremors, other differential diagnosis like Parkinsonism, cerebellar issues, whether he got a stroke affecting his cerebellum. So asking few questions around those areas. When in your examination, so you'd be doing head to toe kind of examination, thinking about again the differential diagnosis, ruling out, ruling in. So investigation, you generally start like general appearance, vitals, and then you go for a systemic examination, system wise. In the general appearance, you will be checking with consideration for your differential diagnosis. Again, you would be asking, or you would be checking from head to toe, but cover all the differential diagnosis. Think about what were the differential diagnosis before. We discussed few, and go through one by one. So in the general appearance, you would be checking, for instance, how he's look like, what's his facial appearance like, is it mask-like faces, or is he having showing any signs of like even tremors, like he maybe head tremors, whether he got them, or like general look. And then you go for his gait. Um, how is his gait? Like, is he like having a shuffling gait, for instance, or is there any imbalance when he walking? Um, then you go for the vitals. In the vitals, you will be checking blood pressure, pulse, respiratory rate, and oxygen saturation, the basic vital signs. Temperature. It's given that he is not having any fever in the history, but still you would be checking those in your office. General exam and vitals, and then you go for the system-wise examination, maybe starting with the central nervous system examination. You're checking for his cranial nerves, and then muscle tone, power, reflexes, and then you would be checking things specifically to exclude Parkinsonism, where you would be checking his gait, and then you would be checking his muscle tone. You can mention this. I would be checking for cogwheel rigidity or lead pipe rigidity, like mask-like faces, shuffling gait, those things to exclude Parkinsonism. Then for the tremors again, you would be checking for tremors. Are they like resting tremors or intention tremor? And then cranial nerves, muscle power tone, reflexes, and then those things to exclude Parkinsonism. And then you would be checking cerebellar signs. So you can mention those things in the central nervous system exam. In the then you would be doing other system exams like cardiovascular, respiratory, and abdominal exam. Cardiovascular, because he's got an AF, right? You would be checking his blood pressure, pulse, and then you would be listening to his heart to see whether you hear a murmur, and even checking for cardiomegaly, for instance, those things. In the cardiovascular and respiratory, you would be checking whether he's having signs of, infection, air entry, and then signs of heart failure. Respiratory wise, abdomen, you generally check for like tenderness, and then you're looking for the liver, spleen, and palpable masses. You can mention those in the respiratory exam, abdominal exam. And then you, after your system examination, you would be doing what we call office test. In the office test, given his history and examination so far, you would be thinking about office test here. The basic one would be urine test, urine dipstick, and then you would be doing random blood sugar then and there, and then you can include an ECG covering diabetes, possible UTI, and then atrial fibrillation here. So that would cover the examination. Then the examiner might ask what sort of investigation you would be doing and why, for instance. And then you have to think about investigations and why you're doing that. Usually in Australia here, you won't just throw in a set of examination without any reason. So you have to reason out why you're doing them. So always, whatever examination you will be doing with a purpose. So the examiners, they ask, if you say full blood count, then you would be telling them why you're doing that. Okay, so full blood count looking for infection, and full blood count looking for hemoglobin, things like that. And then, so the investigation would be, yes, full blood count you can request, and then inflammatory markers, usually CRP here. And then you would be again telling the examiner that I would be doing CRP because I want to exclude an infection here. So full blood count, CRP, ELFT, like kidney function and liver function. Again, kidney function, you will be checking because he's diabetic. And it may be complications of diabetes, and at the same time, liver functions. Again, what is the reason for your liver function? You can tell examiner two things here. One thing would be, okay, he got this hypertension, diabetes, dyslipidemia. He got what we call almost a metabolic syndrome like picture. So he may be having fatty liver, so therefore I will be doing liver function, or he's on atorvastatin. So you can reason out why you're doing liver functions here. And then again, here in the blood test, we can do what we call a dementia screen or delirium screen. In that, you will be doing those tests anyway. Yeah, looking for an infection and looking for a kidney function again, looking for several things: hyperkalemia or hypokalemia, hyponatremia. So those are the reasons for you to do kidney function. In the dementia screen, then, other than those tests, you would be doing a urine MCS again, looking for a UTI to rule out delirium, for instance, coming from a urine infection. Simple thing, but usually common in this age. Then for the delirium or dementia screening, you would be doing a CT brain. CT brain, you're looking for the differential diagnosis again. It will show some changes related to dementia itself, or it may be you looking for a space occupying lesion affecting, for instance, cerebellum or frontal lobe, if he's forgetfulness related to frontal lobe dementia, frontotemporal dementia. First, some things, sorry, I'm going back here in the history, some things I forgot about, but very important. He's an Aboriginal patient, so you have to mention that you would be getting the help from an Aboriginal health worker, and he may not be understanding English very well if he's not using English. Therefore, you can offer an interpreter. Those two things would be the first thing you would be mentioning to your examiner. Aboriginal health worker and the interpreter. Coming back to, okay, I went back to history, so I can add a few more into the history. He's living alone in a rural village, so you would be asking about support mechanisms he has, and then whether he's driving at the moment, or how he's going about of shopping and finding his meals, and does he prepare his meals himself, or is he getting meals supplied by some others, or things like that. Sorry, we come back to the examination and investigations. We were at the investigation. I think we kind of covered what we do, the delirium screening or dementia screening. And then, as I mentioned before, when you do examination or investigations, you would be justifying to the examiner why you doing them, each and every one. They can ask that question. Now he's 76. In the, like, those investigations I mentioned would be the acute setting type of investigations, like related to the presentation. Given this is a PESCI case, PESCI case, like a long case, kind of 45 minutes to 1 hour, or 1 hour to 90 minutes, sorry. So you are expected to request some other investigations, which is like you will be mentioning to your examining GPs that I'm going to do these investigations for this reason. For instance, you will be given he's 76 and he's old, and then you would be checking whether he got osteoporosis. So therefore, you would be requesting a DEXA scan. Here in the case, I saw that DEXA scan score was given as -3.2. That means he got osteoporosis. So that would be given to you if you mention that you're going to do a DEXA scan for this person. Likewise, there's preventative things you would be checking. I would suggest you to read the red book, RACGP red book about preventative uh, investigations you would be doing. There's like, uh, DEXA scan for osteoporosis, bowel screening, and then given a male, it's bowel screening after 50 years of age. Every 2 years, they'll be checking for FOBT, fecal occult blood test. And also there are other preventative measures for the females, like pap smears and then mammograms. So mammogram every 2 years after the age of 50 up to 75 years of age. Same thing about FOBT. It would be like, you can mention this to the examiner because he's 76 now. You would say, okay, ideally I would be doing these from this age to this age, but I will check this whether he need at 76 years of age. Yeah. That is for the investigation, like a long-term kind of investigation. When we discuss about the preventative aspect, in the history, you could ask about whether he covered his vaccines, like flu vaccine, COVID vaccine now, and then pneumonia vaccine, whether he had them before, vaccination history. In the examination in the case, they have mentioned that he got mild confusion and his blood pressure was 140/80, pulse 86, GCS was 14. And one thing I forgot to mention, which is very important in the dementia delirium scenario, would be Minimental Exam, which is a kind of an office test in this sort of setting. So you have to mention that you would be doing Minimental State Exam. In his case, Minimental State MMSC was 18/30. Then that's up to investigation, I guess. And then you would be asked about how you manage this situation and what are the steps you take in your management. So management, you would be dividing it into like acute management now, and then short-term management, and then long-term management. So this is, remember, you are a GP, and then they're checking you whether you can do the things what usually a GP does. So GP may have to deal with a emergency situation or acute setting, depending on the case. And then if it's emergency or acute situation, what is your management would be. And then short term, like for next week or so, what is your management. And then long term, like next months to years, what sort of management plan you have for this patient. So now the patient presented with tremors and recent forgetfulness, and then you have done a thorough history, and you have done examination, and then you requested some investigation. Then the management, you would be discussing this management like short-term, acute management, short-term and long-term. Acute setting, now you have to make sure that so depending on you can discuss this with the examiners. Depending on what you find, you will have to manage it accordingly. If it's forgetfulness is so bad or tremors are so bad, then you have to manage them in that way. You might have to think about organizing some support and referrals, and stopping some medications and starting some medications. Here, with his MMSC, so he's got moderate to severe dementia, that sort of rating here, 18. So moderate dementia, then you have to think about whether he's safe to go back to home, or whether you got support mechanisms put in place. You requested some investigations. So one thing you would be doing is like you getting him back to review with the results sooner, and then you have to organize to see whether, depending on what you find out, whether he lives alone and is there support around him, or if there's no support, you have to organize support, which would be, in this scenario, would be mainly the Aboriginal health worker located in the area or the social worker. Or you can say I would be checking him again after doing a home visit or something like that, or you get him down, or you get the, if he got some family around, you get the family to come in to stay with him, or so some sort of arrangement. So you have to say like, okay, I'm going to do this for the acute setting until you review him again. And dementia diagnosis, then you have to think about referrals. So you'd be referring to a geriatrician, for instance, if you want to. And I mean, if you want to means if you can manage with a phone call, or if you want to do a proper assessment, you do a referral to a geriatrician. I think here it's warranted, so you can do a referral to a geriatrician. Then short-term management. Here, if you find out, you can discuss it like that. If I find a UTI, I will start on antibiotics, and then I'll do this. Is it like for 5 days of Keflex, or 7 days of trimethoprim, or something like that? You can discuss always, okay, if it is. And if tremors due to, say, thyroid issues, then you can say, okay, my thyroid function, I would be looking for these. And then if these are the findings, I would be going this way. If the tremors due to Parkinson's disease, then you would be thinking, okay, I'm referring him to a neurologist, and then he would be starting on, like anti-Parkinsonian medications, and then again thinking about further steps. But acute setting, you would be talking about those, like, okay, I'm referring to this guy or referring to this person, and then I'll be organizing these sort of services, and I'll be getting him down with the results. And then you were given DEXA score of minus 3.2. It is not directly related to his presentation now, but it is like a very high or very low score of DEXA scan score. That means he need to be treated for osteoporosis. So you would be mentioning about, I'll be either using bisphosphonate, or I'll be giving him denosumab or Prolia, which is a 6-monthly injection. So, and then if you want to be sort of, if you want to impress your examiner, then you would be talking about, okay, before I start bisphosphonate, I'll be checking his teeth, or I will be asking him to go to his dentist because of the, one of the complications of bisphosphonate would be, or side effect would be osteocalcinosis of his jaw. So you can mention that to the examiner to show that you know this one. So you mentioned about treating his osteoporosis. Here, in the history, of course, I'm going backwards, sorry. But in the history, you can think about, you would be checking whether he's taking enough calcium or taking enough milk, or whether he's having enough sun exposure, or is he low in vitamin D, for instance, in your investigations. Those can be done. Just that's about osteoporosis. Coming back and sorry, going backward. Management, coming to the management again, short-term or acute and short-term management. I mentioned some of those things, but I may be missing some. If you getting them coming into your mind, you can always express to your examiner. The management again, then long-term management for this sort of scenario would be, there's a lot of things you can discuss. I go back to the breakdown of management: acute, short-term, long-term, and then referrals, like all the referrals you will be doing. So I mentioned about some of the referrals, but I'll come back to some others. Long-term management here, he's Aboriginal patient and he's living alone. And as I said before, you would be checking about his driving capability and whether he's doing driving. So with those in mind, you will be thinking about maybe doing what we call a Aboriginal health assessment or Medicare item number 715, which is like a comprehensive health assessment for an Aboriginal patient, which is funded by the Medicare. So that gives a lot of options, like it's so many visits for specialist and allied health professional like physiotherapy, podiatry, occupational therapy, dietitian, and all of those other health professionals. So you could mention to your examiners that you're going to organize a Aboriginal health assessment, not today, not next week, but in the future, like soon. Once his diagnosis was sorted out, and then once his acute presentation is managed, you will be organizing those things. One would be the Aboriginal health assessment, which is done as a team, like yourself and your practitioners, and then you can refer to a lot of other allied health professionals. And then given he's like, he's got hypertension, diabetes, depression, dyslipidemia, and atrial fibrillation. So he got few chronic conditions. So you can mention about GP management plan or chronic disease management plan, which is again another Medicare funded program which GPs can make use of to help their patients. So you can mention to your examiner that you're going to organize a chronic disease management plan or GP management plan. Along with the GP management plan, you can do what we call a team care arrangement, which is to refer your patients to other team members. Here, your team members would be, say, diabetic educator, podiatrist, physiotherapist for management of diabetes and hypertension, for instance. So you can organize that one. So it's another one in a long-term management. Then another possibility would be he's having depression, right? So you can do what we call a mental health care plan. You can mention to your examiner, I'll be looking whether he got active mental health care plan, or otherwise I'll be organizing one. So that means through that mental health care plan, you can organize him to have psychotherapy. He's on sertraline, but you have to check whether it's under control or whether the dose is adequate. If not, you can increase the dose, or if he's happy with the dose, you will be referring to a psychologist to have some psychotherapy through mental health care plan. You can mention that as well. These are not like acutely managing, but these are your long-term management plans. Yeah. Remember, this is a case of 60 to 90 minutes, right? You can discuss so many things. So all of these would be important for you. These are like general things usually GPs doing here in Australia. So that's why I'm mentioning you all these things. Long term, as I said, those things. Aboriginal health assessment, GP management plan, team care arrangement, those two go hand in hand. And then you would be doing organizing in the future, like mental health care plan for him to have his psychotherapy. Then about, again, when you do all this, say, for instance, if you do the GP management plan, or when you do the Aboriginal health assessment, your practitioners along with you will be working, asking like a lot of practice nurse, or you yourself and practice nurse together, or separately, but it depends. That's why I'm just trying to tell you this. Like some of the clinics, the practice nurse does a lot of work, and GP then come back and sort of sort out whatever the highlighted areas by your practice nurse, or the GP himself does a lot of this planning. Most of the clinics, though, in Australia, it's the practice nurse does all this comprehensive assessment first, and then she or he will be talking to the GP about, okay, our patients need these things now. He need these referrals. He need these investigations. He may need this driving assessment or referral to a optometrist, or he may be needing all these immunizations. Coming to the immunization then, long term, not now, but long term, you will be thinking about whether he had his pneumonia vaccine. Has he covered for those? Or he's now 76, after 70 years of age. Government here funding the Zostavax or herpes zoster vaccine. So he's eligible to have them, so have that vaccine. So you'll have to check whether he has had it, or otherwise you'll be organizing that. And annual influenza vaccine, you can mention all these to your examiners. So that way your examiners will be impressed to hear that the next GP coming to our clinic is aware about all these things of holistic approach of managing a patient. So those are long term. Within the long term management, again, you can mention in your management, somewhere in your management, your follow up plans, like, okay, I'll be doing this blood test, and then I'll be getting him down to sort of check these tests. And then if I find something, I'll be doing these things. And then, okay, my follow up would be like, follow up bloods, like for instance, diabetic control. If it's not under control, you'll be doing HbA1c almost every 3 monthly, or if it's under control, you will be doing it annually. And then you can mention you will be doing annual bloods for, like kidney function, microalbumin, albuminuria, and then you'll be checking for, say, cholesterol, liver functions, everything, like how frequently you're doing them and why you're doing them. So like a follow-up plan. I think I kind of covered a lot of things. I might not have covered everything, but if you handle a case like this, is an example only. This is not the perfect way of handling a PESCI case, but I was trying to address a lot of those things in within this time period, like say 60 minutes.